My name is Alicia Rice, and I'm the Training and Education Program Manager here at MaineHealth Center for Tobacco Independence. I'd like to welcome you to our ongoing webinar series, one part of our comprehensive tobacco treatment and prevention education program, offered on behalf of the Maine Center for Disease Control and Prevention, Department of Health and Human Services. Today's session will be recorded and posted to our website following the presentation. We are offering one continuing medical education credit and one CHES credit for participants who attend the full session live today. To receive CMEs, you must have a Cloud CME profile. Credits will be available in your profile within 1 week. Instructions for creating a profile, if needed, will be included in the post-webinar email. For those collecting CHES credit, your attendance will be submitted to NCHEC after the event on your behalf. Please note that only participants who registered, joined via the Zoom link, and attended the entire session are eligible to receive CMEs and CEUs. And at the end of today's webinar, an evaluation will appear on your screen and will also be emailed within 24 hours. Your feedback is extremely valuable to us and our presenter, and we appreciate you taking a few minutes to complete it. Before we begin, just a couple more housekeeping notes. All attendees are on mute to minimize background noise. The raise hand feature is disabled. If you are interested in a more interactive learning opportunity, we do encourage you to participate in one of our standard core trainings, as this is a webinar. The Q&A box is enabled, so please submit your questions at any time, and that's the Q&A box. We will address as many as we can as time allows, and any questions that we do not get to will be addressed in a follow-up email. And this will also include a copy of today's presentation slides. Those will also go out via email. So today's webinar is titled Concurrent Treatment of Tobacco Use Disorder and Other Substances, and is presented by Edward Perka of MaineHealth Center for Tobacco Independence. At this time, I'd like to turn it over to Edward.
Okay, Alicia, thank you so much. And thanks everybody for joining us today for this discussion about the concurrent treatment of tobacco use disorder and other substance use disorders. So my name again is Ed Perka. I'm an educator on the training and education team here at the Center for Tobacco Independence. I've been an addictions therapist for over 30 years, primarily in New York State as a credentialed alcoholism and substance abuse counselor, or CASAC. I'm also a tobacco treatment specialist, and I've been providing education and training on tobacco treatment to healthcare providers, behavioral health providers, and educational institutions for the past 18 years. So let me set the stage a little bit. At CTI, our focus and our expertise is the treatment of tobacco use disorder, or TUD. At the same time, I think we all understand that we can't talk about TUD as if it's in a silo all by itself. So people with TUD often have other co-occurring disorders as well, and whether that's a physical health concern or a mental health disorder or another substance use disorder, or even all of those at the same time. In fact, we know that the prevalence of tobacco and other nicotine use is much higher in people with mental health disorders and other substance use disorders, and that this population bears a disproportionate burden with respect to tobacco-related diseases. So, as providers of tobacco use disorder treatment, I think it's important that we understand some of the linkages and some of the connections between TUD and other physical and behavioral health concerns, and hence the reason and the rationale for this webinar. So, in the majority of our trainings and webinars, questions about concurrent treatment and best practices are always posed. And it's become apparent that this is an issue that many of us find challenging and could use some additional information and guidance about. So as we proceed, feel free to share any comments or questions or observations or concerns that you may have. as that always contributes to a rich and useful discussion. So let's jump in. So let me share a little bit about CTI first. So the MaineHealth Center for Tobacco Independence, or CTI as we call it, has served as the primary contractor of the Maine statewide tobacco treatment initiative since 2001. CTI administers the statewide tobacco treatment contract on behalf of the Maine Center for Disease Control and Prevention, and we work across the state of Maine to address tobacco use and exposure through education, prevention, policy, treatment, and training initiatives, which is what you're in right now. We provide an array of training opportunities for providers, health professionals, and others, including tobacco treatment specialist training, essential skills training, intensive skills training, a comprehensive webinar series, and tobacco treatment and prevention workshops. And for those of you that might be interested in pursuing the national certification in tobacco treatment, CTI is a nationally accredited provider of the core training requirements through the Council of Tobacco Treatment Training Programs. That's a mouthful. We call it the CTTP. So the completion of these core training requirements is necessary to pursue tobacco treatment specialist certification. And detailed information about that, about the tobacco treatment specialist certification, can be found on our website, which is ctimaine.org. And today's presentation is part of that effort. As we gather in this place, we acknowledge that we are occupying the traditional territory and ancestral lands of the Wabanaki people, who for thousands of years have called this place home. We acknowledge their continued connection to this land, give thanks for allowing us to do this good work on their homeland, and remember their ancestors who were here before us. And please note that references to tobacco in this presentation refer to commercial tobacco use and not the sacred and traditional tobacco used by indigenous communities. And this is our standard disclosure side, just letting you know that we have no relevant financial relationships to disclose. And here are the objectives for today's presentation. We want to describe the mechanisms that link tobacco and other substances together, to explain the effects of comorbid tobacco and other substance use on the structure and function of the brain, to describe the impairments associated with comorbid tobacco and other substance use, to present the rationale for treating tobacco use disorder and other substance use disorders concurrently, and then finally to describe some treatment approaches for co-users of tobacco and other substances. But first, let's do a quick check on your level of confidence. Now, I don't want you to weigh in on this. I just want you to do a bit of honest self-reflection. And here's the question. So on a scale of 1 to 10, with 1 being very low and 10 being the highest, how confident are you that you can effectively treat a co-user of tobacco and other substances? So consider that for a second. So how confident are you that you can effectively treat an individual using tobacco / nicotine and other substances? So in your head, right? So again, I don't want you to weigh in on this. I just want you to think about it. Why did you put yourself at the number you did? And what would have to happen for you to move 1 number higher on the scale? So think about this as we go, as we progress through the presentation. And then again, at the end, we're going to check this again and see if we might have moved the needle just a little bit. So let's start with the rationale for concurrent treatment of tobacco use disorder and other substance use disorders. But first, let's define addiction. The American Society of Addiction Medicine, or ASAM, defines addiction as a treatable chronic medical disease where people with addiction engage in behaviors or use substances that become compulsive and often continue despite harmful consequences. And that's the benchmark, really. They continue to use the substance despite negative consequences, despite it causing difficulties in their health and their daily lifestyle. But importantly, that definition also includes a statement saying that prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. So, does this definition apply to tobacco use disorder? Of course it does. But there still exists a persistent misconception that other addictions are somehow more serious than tobacco, or that tobacco use disorder is a lesser addiction. I put that in quotation marks. The following labels have been used to describe tobacco users. They have a nasty habit. They lack willpower. They lack character. They're moral failures. They don't care about their health or the health of those around them. And due to this messaging, sadly, many tobacco users believe this about themselves, and these descriptions are simply false. What tobacco users do have is a chronic and often relapsing addictive disease of the brain. It's the same disease that someone who is addicted to opioids or alcohol or cannabis or cocaine or any class of drug. What we sometimes overlook, though, is that tobacco use kills almost 500,000 Americans every year. That's more deaths than from AIDS, heroin, crack, cocaine, alcohol, car accidents, fire, murder, and suicide combined. So it's vitally important that we reframe the tobacco problem as a chronic addictive disease that requires treatment and to facilitate all tobacco users access to treatment. And there's another persistent belief among some in the field that we should not treat tobacco use disorder concurrently with other substance use disorders. And that's precisely how I was trained in my early years as a counselor. And what I believe was right for many years. I call it practice wisdom, doing what we thought was effective, although not based on empirical evidence. And you know all the rationales. We can't take away their last pleasure. People need to smoke to relieve their stress. It's their only coping mechanism. They're more likely to relapse if we make them quit smoking. But we now know that all of that is totally wrong. In fact, the opposite is true. So let's explore some of the factors that contribute to the rationale for concurrent treatment of all substance use disorders, including tobacco use disorder. And here's the first one. All substance use disorders, including tobacco use disorder, have similar diagnostic criteria. Substance use disorders are diagnosed using the Diagnostic and Statistical Manual of the American Psychiatric Association. Tobacco use disorders and all of the other substance use disorders have the same diagnostic criteria. And there are 11 criteria. The more criteria you have, the more severe the disorder is. For example, 2 to 3 criteria indicates a mild substance use disorder, 4 to 5 indicates a moderate substance use disorder, and 6 or more criteria indicate a severe substance use disorder. So the bottom line here is that a comprehensive, detailed assessment is crucial to determining the presence and severity of a substance use disorder and has to include all substance use disorders that might be present. And also a comprehensive treatment plan must address concurrently all substance use disorders impacting the health and well-being of the client. So it's been traditional in addictions treatment to focus on the client's drug of choice, and I put that drug of choice in quotation marks, be that alcohol or heroin or methamphetamine, right? We tended to back burner or delay treatment of tobacco use disorders, and this is a mistake. The interconnectedness of tobacco use disorder and other substance use disorders is very compelling, and if we ignore it or delay treatment, that puts a successful treatment outcome in peril. Factor number 2, substance use disorders, including tobacco use disorders, are biopsychosocial disorders. And holistic health is about caring for the whole person, providing for physical, mental, spiritual, and social needs. It's rooted in the understanding that all these aspects affect overall health, and being unwell in one aspect affects the individual in all of the aspects. The biopsychosocial model of addiction acknowledges that addiction is a complex issue influenced by biological, psychological, and social factors rather than solely a biological disease or a personal weakness. And this model recognizes that all three areas interact to impact an individual's risk for addiction, as well as their treatment and recovery. So, if an individual has multiple substance use disorders, it stands to reason that if we don't address all of them at the same time, we're not providing the best possible care. Substance use disorders don't exist in silos. We can't decide to pick and choose which ones we're going to address. There's no such thing as a lesser addiction. Now, we describe addiction as a primary, progressive, chronic, and often fatal disease. Treating one disorder while ignoring another disorder is not holistic treatment and not best practice. Factor number three, substance use disorders, including tobacco use disorder, involve the mesolimbic dopamine pathway. So the limbic system is one of the oldest structures of your brain, and it produces natural instincts that our ancestors used to survive by triggering behaviors needed to eat, to drink, to reproduce, to care for young, and to react to surroundings such as the fight or flight response. Now, the mesolimbic dopamine pathway is a specific circuit within the limbic system, projecting from the ventral tegmental area, which you can see labeled as the VTA, in the midbrain to the nucleus accumbens. And keep those two things in mind because we're going to look at those in a second on a different slide. And the mesolimbic dopamine pathway, that drives things like reward and addiction and motivation. So all addictions, including tobacco addiction, involve the mesolimbic dopamine pathway, and we often refer to that as the brain's reward center. So dopamine, as you know, is a chemical that gives us pleasure. It impacts motivation by marking experiences as essential for survival, and we want to repeat them over and over again. The problem is that psychoactive substances, nicotine included, cause very high levels of dopamine to be released. So, in effect, in that very deep part of the brain, people are getting the message, I must continue this behavior in order to survive. And then, on the other hand, the prefrontal cortex is responsible for executive functions, including cognitive skills that are needed for things like self control and managing behaviors. And these functions allow people to do things like follow directions and focus, control their emotions, like all of you, right, are doing right now. And also the consequences of our decisions and actions are taken into consideration. So that prefrontal cortex is like a red stop sign, a stoplight to behavior with negative consequences. And the reward center is more like this green go light to continue whatever behavior feels good. So what happens with substance use over time is that the prefrontal cortex gets weaker and the reward center of the brain gets stronger. In addiction treatment terminology, the reward pathway hijacks the brain. And to further complicate the situation, after repeated exposure to substances, the brain cells can change. And the effect of this change is that it reduces the body's ability to release its own natural feel-good chemicals. So what starts out as a like becomes a want and then a need, and that turns into an obsessive drive to keep seeking more and more of the psychoactive substance. Factor four, although substances may initially affect the brain differently, the end result is the activation of the mesolimbic dopamine pathway. So here's where I said, keep in mind the nucleus accumbens and the VTA. You can see those inside that little box, right? And that's the mesolimbic dopamine pathway. So this is a very simplified, basically a very simplified flowchart of how different substances act in the brain. And represented here along the top, you can see alcohol, nicotine, cannabis, and opioids. So what happens is initially alcohol binds with neurotransmitter GABA receptors. Nicotine binds with a different receptor. It's called the nicotinic acetylcholine receptor. And cannabis binds, or THC, binds with CB1 and CB2 cannabinoid receptors, and opioids bind with what we call mu opioid receptors. So they all act a little bit differently at first, right? But in the case of addictive disorders, all pathways lead to the same place. Those are the red arrows. And that place is the mesolimbic dopamine pathway. And the result is a surge of dopamine. Research shows that this dopamine burst can be 10 times greater than the dopamine response from simple pleasures like eating good food or winning a game or earning money or having sex. So think about it this way. The brain is very good at remembering what causes positive experiences. This reinforces the likelihood of repeating those behaviors that result in those experiences. Since all substances, including nicotine, have a similar effect in the dopamine pathway, the use of any substance will keep that pathway active. I like to think of it as keeping the addiction pathway lit. In addictions treatment, abstinence from all psychoactive substances is the ultimate goal. It's not okay to drink, for example, if you're trying to stop using heroin, right? It's clear that the risk of returning to use is much greater if you don't stop the use of all substances. So we now understand that we need to include nicotine in this equation. Any substance that keeps the addiction pathway lit leads to that greater chance of returning to use of those other substances. Factor five, genetics is a factor in the development and the risk of substance use disorders. So research by the National Institute of Drug Abuse, or NIDA, shows that genes are responsible for about 40 to 60% of the risk for addictions. And while genetics are not the sole determinant, their presence or absence may increase the likelihood that a person will become alcohol or drug dependent. So it's possible to hypothesize that there are common or shared genetic factors that increase the risk for both tobacco use disorder and other substance use disorders. And interestingly, some studies have demonstrated that the same genetic factors responsible for substance use also play a role in the development of things like impulsivity and conduct disorder, as well as a general propensity for all substance use and misuse, or things like sensation seeking or general problem behavior. And this is common with all substances, including nicotine. Factor six, there are common environmental, behavioral, and social triggers. So a trigger is something that brings up a memory related to drug or alcohol use, which leads the brain to anticipate a reward and causes a craving response. So triggers can be things like people, places, things, even feelings. So the formal psychological definition of a trigger is a stimulus that elicits a reaction. In the case of addiction, the trigger is the stimulus that initiates a craving response in someone with a substance use disorder or who may be in recovery from a substance use disorder. And many things can serve as triggers for someone, and each person's triggers are different. So physical triggers can be people, places, or items that are associated with previous substance use. Avoiding physical triggers can be challenging for many people, especially if they are friends, right, or family members. And as we know from the biopsychosocial model, emotions such as depression and stress and frustration and anxiety, they may provide that reflexive desire to use substances to relieve the discomfort of that emotion. And likewise, the environment can play a significant role. So a dysfunctional or isolated living situation can trigger addiction memories, right? And that can increase the risk of substance use. A person can be triggered by visiting an environment or even driving through a neighborhood that provokes addiction memories. And then certain behaviors and patterns may serve as triggers for substance use. So these habits vary from person to person, and they might even include things like negative self-talk or thoughts of shame and guilt. So the takeaway here is that these triggers, which we sometimes call cues, are common to all substances. So the physical, psychological, environmental, and behavioral cues trigger the reward system to anticipate and seek that pleasurable experience. And the fact of the matter is, tobacco use is very often concurrent with other substance use. For example, smoking and drinking often occur together, as is the case with cannabis also. Stimulant use and opioid use are often concurrent also. So, in essence, what causes a craving for one substance often causes a craving for all substances. So, if a person continues to smoke, the use of nicotine is going to keep that addiction pathway active, and cravings for their drug of choice, again in quotation marks, will be intensified. So it's not hard to see that if a person keeps using tobacco or other nicotine products while trying to stop other substances, the chance of a return to use increases. So let's take a closer look at the interactions between tobacco and nicotine use and other substance use. And we'll start with cannabis. So just out of curiosity, I want you to weigh in on this one. Um, what do you think the answer to this question is? What percentage of adults who use cannabis also report that they use combustible tobacco products? So you can use the Q&A feature to weigh in on this one. I'm just curious as to what you think about this. What percentage of adults who use cannabis also report that they use combustible tobacco products? And I will pause for a minute or two or less.
Edward, I'm seeing a few. I have a couple of Bs, so
Okay.
78%.
Okay.
I have a 52%.
Gotcha.
I have a 94%.
Gotcha. Yeah, these kind of questions are kind of like wild guess questions, right?
They
But
are.
yeah,
Yeah,
I like the
I
range.
currently do not have a 26%.
Okay. Well, that's good because that's not even close. Now, recent studies show that about 78% of past month adult cannabis users reported past month tobacco use. And we see that trend in both males and females, different age ranges, and most different racial and ethnic groups as well. So, one interesting fact of tobacco and cannabis co-use is that the route of administration for both is predominantly inhalation by smoking. So, the smoking of one substance may impact the use of the other. For example, a tobacco user who experiments with cannabis may continue to use past experimentation simply because the experience of inhaling smoke is more pleasant for them than for a non-tobacco user. And tobacco users may also experience more positive subjective reactions to cannabis. So there's a higher satisfaction, therefore they continue to use it. And then co-administration, which is the use of both substances at the same time, may have an additive effect. And that means that greater pleasure is experienced than from using either substance alone. And there is also some evidence that each drug may reduce some of the unpleasant effects of the other. So they're both positively reinforcing and negatively reinforcing. And we'll talk a little bit more about that in a second. So, what about tobacco and alcohol? So, alcohol and tobacco co-use has patterns very similar to that of tobacco and cannabis. So, people who drink alcohol are much more likely to smoke than non-drinkers. And conversely, people who smoke are much more likely to drink alcohol than non-smokers. And in addition, smoking and drinking is almost always concurrent, right? That is, they're used at the same time. And this is true for tobacco and other substances as well, but it seems to be most prominent with alcohol. So drinking alcohol may cause an urge to smoke, and smoking may cause an urge to drink. And then alcohol and tobacco co-use has patterns very similar to that of tobacco and cannabis. So people who consume alcohol are more likely to smoke. Again, people who smoke are more likely to report drinking alcohol, and they almost always occur at the same time. So in addition, alcohol and tobacco tend to enhance each other's rewarding effects. So in other words, drinking is more rewarding when used in addition to smoking, and smoking is more rewarding when used in addition to alcohol. So smoking also reduces the sedative and intoxicating effects of alcohol. And here's that we're coming back to positive and negative reinforcement. So we can see that co-use of alcohol and tobacco may be positively reinforcing. That means it gives a reward, and also negatively reinforcing, meaning that it removes each substance's or some of each substance's unpleasant effects. Okay, here's another weigh-in for you. So, what is the tobacco prevalence rate among patients with an alcohol use disorder? All right, so what percentage of individuals with an alcohol use disorder also use tobacco? Let's see what you think about this one. What percentage of individuals with an alcohol use disorder also use tobacco?
We have a majority of 70 to 80% and 80
Hmm.
to 90%.
And that is right. The answer is 80 to 90%. So people with an alcohol use disorder have very high levels of tobacco use. And of course, this is confounding, right? Because very often, as we've mentioned, smoking and drinking are done together. And so this makes the treatment of these disorders more challenging. And it's also a factor that reinforces concurrent treatment. Also, people with an alcohol use disorder who also smoke are more likely to die from their tobacco related illness than from their substance use disorder. So, just a quick question. Do the names Dr. Bob and Bill W. ring a bell with anybody? You don't have to weigh in on this one, but do the names Dr. Bob and Bill W. ring a bell with anybody? Dr. Bob Smith and Bill Wilson were the founders of Alcoholics Anonymous back in the 1930s. And both were obviously serious alcoholics, right? But they were also both heavy smokers. And guess what? They both died of smoking related illness and not as a consequence of their alcoholism. Okay, so let's continue with tobacco and opioids. So we tend to see the same pattern in the co-use of tobacco and opioids that we see with the other substances. So people who smoke are 3 times more likely to report non-medical use of prescription opioids. So I consider that prescription medication abuse. And here's an interesting fact, up to 95% of individuals who take methadone or in methadone treatment also smoke cigarettes. So think about trying to quit um, heroin or prescription opioid medication. So you can't do that by going cold turkey. It usually doesn't end in success because the symptoms of withdrawal are so severe that users relapse to opioid use, continue, return to use. A much more effective and humane way to stop using is to use methadone maintenance treatment or by using medications like buprenorphine or Suboxone. But interestingly, almost the exact same thing can be said about quitting tobacco. So using tobacco treatment medications to help a person stop smoking is in effect a type of medication assisted treatment. And here again, we see an intimate relationship between smoking and opioid use. So regardless of the type of opioid or opiate used, nicotine tends to interact to increase overall substance intake. Let me read that again. Regardless of the type of opioid or opioid used, nicotine tends to interact to increase overall substance intake. In other words, if you smoke, you're going to use greater amounts of heroin or prescription drugs, and the reverse is true also. And just an interesting tidbit, patients who are maintained on methadone report that smoking is more satisfying to them. So they're using methadone and smoking at the same time. They're saying that smoking actually is more satisfying to them. And finally, our last category, tobacco and stimulants. So, not surprisingly, similar to other substances, there are significant interactions between nicotine and a variety of stimulants. For example, when people use cocaine and also smoke, which is very common, each substance enhances the positive effects of the other. And that's another example of positive reinforcement. And the interaction between nicotine and cocaine actually enhances what we call extracellular dopamine or an increase in dopamine, and that increases the intensity of the effect of both drugs. And in addition to the positive reinforcement, nicotine tends to lessen the adverse effects of repeated stimulant use. So when you're smoking or using nicotine products, the bad effects of using a stimulant are lessened, right? So things like apathy and depression and exhaustion, hyperexcitability, irritability, those things are mitigated to some extent by using nicotine. So this is another example of what we call negative reinforcement. So in effect, nicotine use facilitates the use of greater amounts of stimulants than would be used in the absence of nicotine. So, kind of in summary, in addictions treatment, I call it a laissez-faire attitude toward tobacco treatment. And that means, oh, we're not treating it in the same way as we treat other addictions. We're considering it to be a lesser addiction. That means that we are not providing the best possible care for our patients and our clients. So uh, helping a person to stop smoking is one of the best things we can do to help them break the chain of addiction to other substances. Addiction is truly a biopsychosocial disorder. It has complex physiological effects. In many cases, medication assisted treatment is the best treatment approach, not for every class of drug, but for some. But in addition, counseling and support should be encouraged to address the psychological and social aspects of the person's circumstances. So, but for all addictions, practical counseling like coping skills training and problem solving and stress reduction are also needed. So let's talk just for a moment about how to engage patients in the treatment process. So the best practice is to treat tobacco use disorder and other substance use disorders concurrently whenever possible. And as we mentioned, addiction is a primary, progressive, chronic, and fatal disease. It doesn't matter what the substance is or whether the course of the disease differs for different substances. We're not providing the best possible care if we ignore one addiction while trying to treat another. The linkages, as we've just seen, are too strong. So research is clear. Treating addictions concurrently tends to result in better treatment outcomes and stronger long-term recovery. People are serious about their recovery, and you see that every day. So our job is to make sure that we're providing the best possible treatment for our clients and our patients. They look to us for guidance and direction. So the evidence now tells us that quitting tobacco, along with a person's drug of choice, again, quotation marks, actually makes recovery stronger. It's not a relapse dynamic like we used to think. In fact, the opposite is true. Continued smoking makes relapse more likely. So here's a message you can give to your clients and your patients. One of the best things you can do for your recovery is to quit smoking. Let me know when you're ready I can help, right? Let me state that one more time. One of the best things you can do for your recovery, and this is from other substances, is to quit smoking. Let me know when you're ready. I can help. So here's the bottom line. Providing tobacco use disorder treatment concurrently with treatment for other drugs improves smoking outcomes. And smoking abstinence does not lead to an increase in other drug use. And on account of all the factors we've talked about today, when individuals keep using tobacco while they're trying to quit other drugs, they are more likely to relapse to those other substances. So concurrent treatment is best practice. Question is, what does that treatment look like? So let's look at some treatment approaches for individuals who use tobacco and other substances. First of all, your approach really matters. So we're not wrestling with people or trying to convince them. We're helping to create a space in which people can consider making a change. And there are very effective substance use disorder treatment interventions, but there are also very ineffective treatment interventions. What's an effective intervention? It's one where the individual feels supported, they feel understood, and they don't feel judged, right? They also are free to think about stopping their substance use, and hopefully they've taken one step closer to that ultimate goal. So, how do you accomplish that? You accomplish that by engaging the individual on a level of compassion and empathy. If I was in a room with you all right now, I would ask you to raise your hands if you didn't have compassion or empathy, right? Not one of you would put your hand up, right? So that's a quality we need to have with our patients and our clients by understanding that they have a disease, right? And not a character flaw or or lack of willpower. And we also want to recognize that complex emotions may be present, like shame and guilt and hopelessness. These are normal and are to be expected. And we also want to realize that people who use substances are typically aware of the associated risks. They know that. We don't have to spend a lot of time convincing them that their substance use is bad for them. They know that already. I also like to ask permission to give information. In fact, this is one of my favorite things as a therapist. One of my favorite tools that I use. The other is the scaling question, which I've introduced to you with the confidence scale. Ask permission to give information. It respects the person. It makes them part of the conversation. It's person-centered care, and it helps to create that safe space for your clients and your patients. And above all, be compassionate. Let them know that you really care about them. Here's one of my favorite quotations. This is from Teddy Roosevelt, and he said, quote, "People don't care how much you know until they know how much you care." Love that quotation. And finally, legitimize their struggle. And by that, I mean acknowledge that a substance use disorder is challenging to overcome, right? As we talked about the mesolimbic dopamine pathway in the brain changes, and you're going to support them on their journey to recovery. So it's important to keep certain things in mind about the individuals that we serve, right? Again, they may be coping with enormous emotions, shame and guilt. They may have dealt with providers in the past who have lectured them and scolded them, right? Assuming that perhaps threats are going to induce them to quit. And clinicians may have acted like the expert that the individual needed to listen to, not a caring collaborator in their care. And that causes people to feel unheard. They may have tried to quit many times before to the point that they feel hopeless. And here's why it's important to remember how much your approach matters. Tap in to your empathy and compassion. Your patients or clients, they're going to be able to feel that. Let them know that their struggle is real and you get it. And this begins to create that safe space for them to share with you. And it's always possible to that you'll be asked about your own history of substance use. And this is particularly true about um, tobacco and nicotine use. And what should you do? And you should be honest with them. But our recommendation is to keep any self-disclosure brief. And self-disclosure sometimes can be helpful for individuals to hear that you were once addicted and you understand their experience, but it can also be a distraction from the momentum of treatment. So you have to be cautious about self-disclosure. But in general, more listening and less talking is the preferable course to take. And this is very interesting. We have some research that shows that the current 7 first-line tobacco treatment medications can also have a positive effect on other substances that a person might be using. That is, tobacco treatment medications by themselves can decrease the use of other misused substances and also enhance treatment outcomes, which is really kind of cool. And these are the 7 first-line medications for treating tobacco use disorder. This isn't a presentation on medications, but just a quick note here that we will soon have another FDA-approved non-nicotine medication on this list, and that is called cytisinicline, which has a mechanism very much like varenicline. So final approval of this medication is expected in June of this year, 2026. So I've included a great handout for you as a resource, and this is the tobacco treatment medication dosing guidelines. It contains detailed information about how to use these medications. So I encourage you to take a look at that. I also encourage you, if you want to find out more about tobacco treatment medications, to look at our training offerings because we offer a bunch of stuff on medications that can enhance your confidence and competence when you talk with people about tobacco treatment medications. And tobacco treatment medications, as I said, by themselves, um, are effective, but also they have very few significant interactions with other substance use disorder treatment medications, like you see listed on the slide. So these are medications that are useful for treating alcohol use disorder and medications for treating opioid use disorder. And we don't have to be concerned a lot about NRT and the other non-nicotine tobacco treatment medications interacting with these because there's very few interactions. However, it is important to note that tobacco smoke and not the nicotine causes major interactions with some medications by affecting liver enzymes. So as a result, quitting smoking can significantly increase blood levels of medications like methadone or clozapine, for example, and that necessitates dose reduction. So whoever's prescribing medications for their patients needs to be aware if the patient quits smoking, cuts down smoking, stops smoking, stops using nicotine because the tobacco smoke affects the metabolism of those medications. So for your reference, I've also included a handout on drug interactions with tobacco smoke. And a lot of the drugs listed on there are drugs used in mental health treatment, psychotropic type medications, but other medications as well. Now, I know that there are some MPN partners on this webinar that you're not doing substance use disorder treatment in your work with MPN, and that's understood. This is kind of general knowledge for people to have. But let's circle back at this point and do another check of your confidence level. Do you remember this question from the beginning, right? So, how confident are you that you can effectively treat an individual using tobacco/nicotine and other substances? And whether this discussion we've had today was a refresher for you or you learned something new, I hope we move that needle just a little bit. So in all cases, keep up the good work. So I'm going to shift gears here and wrap up by talking about some resources that are available for you and the individuals you serve specifically for tobacco use disorder treatment. So first up, I'll talk about the Maine Quit link. It is a terrific program, as the slide says. It's free, confidential, and it really does work. If there are people on this webinar from outside of Maine, um, when you dial that number, 1-800-QUIT-NOW, if you're in Maine, you get the Maine Quit link. If you're in New Hampshire or Virginia or New York or Pennsylvania, you get your state quit line in that state. So that's a common number for access to quit lines. This is a suite of services that the Maine Quit link offers. So you can see there's a lot of different things that people can do and tailor their treatment their own way: phone coaching, online tools, medication support, websites. And we do also have a tailored youth program called My Life, My Quit, which is right here. So the My Life, My Quit program was developed with youth input and provides free and confidential coaching to teens who are trying to quit combustible or smokeless and other electronic tobacco products. And you can learn more about this program by going to mylifemyquit.com. And finally, I'm going to share a few additional trainings and learning opportunities and resources that are available for you and your colleagues. So be sure to spend some time on our website, ctimaine.org. Sign up for our newsletter. You can see that green box up on the top, and you'll get updates about our upcoming trainings. Our website has a calendar of our upcoming trainings, and most are eligible for CME, CEU, and CHES credits. And our digital material database of provider tools can be found at ctimaine.org under resources. And print copies of the adult provider and youth provider toolkits can also be ordered for free at ctimaine.org/resources. And the online Maine Prevention Store has digital and hard copy materials that you can order for free. You can get free things like free handouts and posters and stickers and smoke-free area signs and so forth. And that brings us to the end of my part of the presentation. As always, we're always happy to hear from you with any questions, comments, or suggestions. Here's our email for you and our website. And here's just my closing thought for you today. We're all individuals, we're all unique, and we're all different in our attitudes, values, and beliefs. But there's one way we're all alike: the desire to help others find their own path to health, vitality, serenity, and recovery. So thank you for being here today, and thank you for all the good work that you do. You make a difference. Enjoy the rest of your day. Peace. And I'm going to shoot it back to Alicia to see if we might have any questions, or I know you have a couple of wrap-up things to share.
Yes, thank you so much, Edward. There are a few questions that have come into the chat, and we have time, so I am going to fire away. So, Ed, when you refer to cigarettes, does this apply to all forms of nicotine like vaping and pouches?
It depends on the context that you're talking about, but generally, there's certain differences in terms of effect. If you're talking about combustible tobacco versus vaping devices. So if you can add a little bit more context to that question, that would be really helpful. Like, are you asking in what circumstances that we're referring to both, or it would be helpful to know a little bit more context there.
Sure. I will hopefully let Selena chime in and get back to us on that.
Okay.
Um, I did have another around that topic too. Someone mentioned that's outside of Maine. Interesting that where they're from, teens use the term smoking, quote unquote, to mean smoking marijuana, since the vast majority of them are vaping nicotine.
Mm.
Just curious if this changes the incidence of use of other substances and what your take is on that.
What's really interesting about that, and that's a really interesting comment because when we do assessments, particularly with young people, it's very important that we ask them specific questions. So, for example, if you ask somebody, do you smoke? And they think you mean, do I smoke marijuana? And they don't, let's say they smoke cigarettes, but they don't smoke marijuana, they're going to say no, right? So, one of the questions that a provider shared with us that they ask of people is, um, do you inhale anything? So that would cover the gamut, whether it's a combustible product or whether it's um, cannabis or whether it's tobacco or whether it's an electronic device, for example. So I think it's important about how you ask that question. It is a confounding factor for especially for teens when they're using both substances. Um, if you're smoking both substances, there's a profile of issues and concerns about that. If you're using non-smoking forms of nicotine, and you can use non-smoking forms of cannabis as well. You can vape cannabis or you can use edibles to get your cannabis. So that's one of the reasons why I said a very, very detailed, comprehensive assessment is going to be really crucial when trying to figure out what the next steps are. What's your treatment plan going to look like? What's um the profile of the issues that you're going to be dealing with? What does that look like? So it's really important to know in some good detail about what the individual is actually using and in what quantities and in what form, because that changes the profile of the effects of those substances. So I kind of was a long-winded answer. I hope that that was helpful in some way.
Thank you so much, Edward. And back to Selena. So that was the original question on applying nicotine like vaping in pouches.
Hmm.
So the context in reference to use with other drugs for positive and negative effects.
Um, well, I'm still a little bit unclear. Is the question, is smoking different than other substances? So I'm a little bit unclear. Maybe is there any like I would open this up to um if we do I have is Bonnie on the line?
She is.
Yeah, I'm not sure. I just wanted to open it up because I'm not really clear on what again on what the ask is.
Okay. Selena did reach out and she is going to connect with you, Edward.
That would be great. Yeah, then we can talk that one through. Okay.
She has you on speed dial. Just
And that's
kidding.
okay. No, I know Selena. So
Of course.
yeah, that's good. Sorry,
Oh,
I'm
great.
sorry I'm
And
being obtuse,
sorry,
a little
no
obtuse about that,
worries.
but yeah.
And Bonnie, I can't get her off of mute. She's not
Oh,
listed as a
okay.
panelist. I
All right.
apologize.
All right.
Um,
Of course,
let's
I guess
see.
we could ask everybody if they want to weigh in on that as well. If they have any
Sure.
thoughts or ideas about that one.
There's a few questions that we won't be able to get to, but we certainly will provide responses in a follow-up email. But just one more quick one if we can. If a
Sure.
provider asks if a patient inhales anything, my first thought would
Yeah.
be using inhalants, not smoking. Is it appropriate to ask, do you smoke nicotine or marijuana?
Oh, yes, of course. Yeah. That was just that one person's way of trying to cover the bases because it's so the language of adolescence now is um, sometimes very hard to comprehend or understand. So that was just this one provider's way of trying to, cover the bases on that. But yeah, I mean, any more detailed question that you want to ask is going to be very, very helpful. So yes, you could ask that, absolutely ask those kinds of questions. Yes,
Excellent. Thank you, Edward, and thank you so
sure
much for
thing.
your time. Like I said, any questions that we were unable to get to, we will provide in a follow-up email. Just a reminder that today's session, the recording will be posted on our website in a couple of days. Also wanted to share that the slide deck, the two handouts that I included in the Q&A, and any other additional resources will be summarized in a follow-up email. Please, as I mentioned at the start, if you'll see an evaluation pop up on your screen. We do greatly appreciate your feedback and hope you'll take a moment to complete it. If you have any questions whatsoever, please feel free to contact us, email on the screen. And just as you know, CME credits, you must have a cloud CME profile. Full instructions will be included in that post-webinar email. And those seeking CHES credits, your attendance will be submitted to NCHEC on your behalf in the next few days. And again, Edward, thank you for your time, and I appreciate all of you for joining us.
Great.
We'll hope to
Thank you,
see you
everybody.
soon.
Have a
Thanks
good day.
again.